one of our eminent faculty, Dr. Radha Venkatesan, who is a anesthesiologist as well as a palliative care physician. So, Madam has a lot of experience in palliative care and also in the field of anesthesiology. And now she is working as a honorary palliative care physician uh, in Pallium, India. So, ma'am, she is a well-versed person in this field. She is one of our eminent teaching faculty also. Ma'am, welcome and over to you.
Thank you very much, Shiva. As always, warm welcome to the whole team, and a big thank you to Pallium India for giving me this opportunity. And in palliative care as such, pain forms a very big part. So as Sister Shiva was mentioning, it's important for us to understand what it is, because nearly 60 to 80% of what all of you will be having to deal with will be managing patient's pain. Because as you would have all heard, what is palliative care is to alleviate or relieve suffering. And pain is one of the important things in it. So if you have a good knowledge of it, then managing it is not going to be difficult at all. So it's going to be easier once you all get to know what is pain. Then you will have few sessions on management of pain, and then you will all become experts in it. Okay. Thank you very much, Sangit. We'll go ahead with the presentation. Okay. Okay. Coming to, as we were talking about getting the knowledge of pain, first, what is pain? And from that point of view, initially in 1979, definition of pain was given. And the pain definition is given by an organization and a team of people who are experts from all over the world, so that it is something which can be adopted universally. So from that point of view, initially one definition was given in 1979 by there's an organization called International Association for Study of Pain. So that definition was given. But what they did, because it was given in 1979, in the year 2020, they have slightly modified the definition with adding on important elements to it. So that is what we are going to see today. So what is written in the slide is the primary definition. So pain is defined as something that is unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. And along with it, they've added on 6 important keynotes with the definition. So I have highlighted few things here. There is a reason for it. Because is pain anytime pleasant? Is anyone happy when they have pain? No, not at all. So it is an unpleasant, and it can be physical, sensory part can be there, or an emotional experience can also be there. So both together are components of pain. So that is why I have enlightened. So the physical and emotional part have an equal role. And then next, the highlighted one, actual or potential tissue damage. Actual means physical cut can be there, or sometimes it may not be a direct physical cut, maybe due to other factors which we will see through our presentation today. See, for this, I normally give a simple example. All of you should be aware, when someone has surgery, there is a lot of retraction. So when surgery is done in any part of our body, okay, so when that retraction happens, and our structures are normally all together. Neurovascular bundle, you would have all heard that. What is that? It has artery, vein, nerves all in one sheath or something like that. So like that, the whole body has many such structures. So whenever retraction or something is done, there may be shearing force acting upon the nerves when some other surrounding structures are also dealt with. So that is what is meant. So every time there need not be a physical cut. There may be these types of other types of injury which can be there. So that is why everything has to be kept in mind when you are going to understand about it. So the highlighted elements in this slide are important. Next slide, please. Next comes the 6 important points that they have added. What are the 6 important points? Every point mentioned here are important. Pain is a personal experience. In the definition itself, we saw it is sensory and emotional. So here what they have mentioned is, so each one of us, all of us are not the same. And if we were all the same, it will be boring in life. So that is why we are all made like what we are. So each one has a personal experience along with the physical injury. Okay, that is what is to be understood here. So when one particular injury happens, there may be other so many personal factors also involved with it. So that does have a role to play. Next, what is the difference between pain and nociception, which we will clarify through the presentation today. Third one, patient's expression of pain is to be respected. An example I'll say, if next when you all see patients, someone may come and say, I am in severe pain. Okay, and pain is a subjective symptom. So we have to respect that. If the patient says that they are in severe pain, we cannot belittle or consider, no, you're not in pain. Those type of statements or gestures should never be made, because it being a subjective phenomenon, we will not know what is the patient's experience. And also, all patients may not have the same threshold. For example, patient A may have a higher threshold. So he may tolerate pain to a greater extent. You may have a patient B who may not even tolerate anything. So that is what is conveyed here. So whatever the patient says, we have to accept that and not only accept, respect that, and that is where from you will have to go to managing the pain. Next, life experiences do have a role. That is what was said in the first, personal experience and life experience. Along with that, for example, when one person has a physical injury, what is the impact it causes to them? That moment and surrounding that incidents or happening does have a very big role to play. And next, usually pain is said to be a symptom. For that, good example will be if there is right iliac fossa pain. What do you infer from that? Anyone can answer or type in the chat box. Sanket, if someone types in the chat box, at present, when I'm presenting, you may have to look at it because I may not be able to see it on my screen. Okay, so anyone can say if some there many are typing. Okay, appendicitis. I can see that, but maybe communicating. So that's what I wanted you to see, because once many messages come. So very good. So what? So that symptom was helpful for you to find out. Okay, so generally pain is taken like that, but there is another element of it too, but can become a problem too. When some symptom lasts for too long, then that can be not of a benefit. See, right iliac fossa pain is helpful to diagnose appendicitis. then you go ahead. Oh, are you going to do medical management or are you going to do surgical management? So it gives you an option to clinch the diagnosis and then move forward to the management plan. So as long as it's a symptom helping in this, very good. But for example, long drawn pain, very good examples are back pain, one injury, lifelong pain. So there, that is what is mentioned here, but can become a problem too. And how and why it becomes, that we will see through our session today. Then verbal expression is not the only way to express pain. What is conveyed there? If someone can speak and tell I am in pain, yes, but is that the only way? Are there any other ways? Anyone wants to share or say something? Then I will go ahead and explain also. Is there any other way of expressing pain other than telling I am in pain?
मैम पेशेंट हाथ लगा के ऐसे एक्सप्रेशन दे के भी बता सकता है कि मुझे
हाँ
यहाँ कोई प्रॉब्लम है बिना बोले।
हाँ हाँ, सब कुछ ठीक है। बात करने भी एक ही मार्ग है, अन्य को भी मार्ग भी है। For that normal example, I would say intensive care patients, intubated patients. What are the ways? What are the other ways other than patient telling they are in pain? How else can you find out?
When we touch the patient, then vitals will be abnormal.
Vitals, exactly. That's very good. Blood pressure, heart rate, everything will not be normal. So there, and another one very good symptom or sign would be sometimes patient may have some tears. So especially in ventilated or intubated patients, see, nowadays we don't paralyze the patient if the patient is ventilated. So that also. So there are other means. Okay. So that is what is mentioned here. So verbal expression is one of the ways of expressing pain, but there are other means also. Next slide, please. Okay, this is something like it's a nutshell diagram of the pain pathway. Okay, so from the periphery, if you see, like periphery, like for example, if there is you see a sharp prick, what happens actually at the site of injury? See, this sharp prick is one example. There are many ways. Is prick the only pain? You have pain in from various sources. Joint, that is stretch or mechanical origin. So mechanoreceptor, sensory receptors, and then visceral. You have what is something like we saw appendicitis. That is pain caused inside the abdomen. So there can be very many types of primary receptors which are conveying the pain. So at the site of injury, there are some chemical mediators. So primary sensory neurons are there. And what all is mentioned there? Chemical mediators which are released cause a collection of, it can be a big group of chemical mediators released, and there initially the release happens, and then that is how information is conducted. So this gives you an overall, if we go into detailed explanation of this, one picture can go for hours, but I've put this on just for you to have an idea. From the site of pain, you have chemical mediators released, then the information is carried by the afferent nerves to the spinal cord, dorsal horn, then the crossover of nerve fibers happens, then you have the ascending pathway, and in the brain as such, many modifications happen. And then you have the descending pathway, which is mainly an inhibitory pathway. All these physiology is important for you to understand the pathophysiology of pain. So that is why I mentioned. And then finally, you have the efferent nerves, which bring the information back to the site. That is how you perceive pain. Okay. This conduction is what is nociception. Okay. So this is an overview, pictorial overview of the pain pathway for you to keep in mind. Next slide, please. So what is the important thing that we need to understand in the pathophysiology? This whole thing, what you saw in the picture, is not a simple one. It is a complex phenomenon. And the complexity results because of one simple thing called as it is not a hardwired system. See, you saw, as I mentioned, you have the nerves, connection, and then they go up to the brain, they come back, all that. You saw it as a system, but it is not a fixed path. Okay? But it exhibits plasticity. That means what? That it enables it to modify its function under different conditions. It is one path is there, but it need not be a fixed path. Sometimes, for a few examples which we are all aware in our own physiology is collaterals. Okay, that is, it takes one route is there, it can take another route, or it can have other types of phenomenon which we will see through our presentation today. So it is not one fixed pathway. So this is the whole pathway there, but the system can modify all these words. No, they are very, very important. Plasticity means it enables it to change. So it can modify its function under different conditions. That is why we have various types of pain. Okay, so important thing is the whole pathway is there, but it doesn't function only as a hardwired one fixed route. It doesn't follow, or fixed method of conduction. It does not follow. It has the ability to modify its function under different conditions. That is the important concept to be understood here, because this is something very important. If you understand, because that is why, otherwise, pain is something simple. One fixed path means it would have been easier. But if you understand the concept that it is it exhibits plasticity and it can modify, then we can manage the consequences also. That is the important. Next slide. So that comes, then we come to neuroplasticity. What is neuroplasticity? It is the capacity of neurons and neural network, okay, in the brain to change their connections and behavior in response to new information, which could be sensory stimulation, developmental change, damage, or dysfunction. See, in all these slides, every word is important, okay? So that's why we expand on these. So as I said, it's not a fixed, it's not only one fixed pathway. And why is this possible? Because it is possible by the neurons and the whole network to change their behavior and connections depending on the new information. See, it could be a sensory stimulus. And as I said, it could be primary a sensory stimulus, but it could add on sympathetic function also. So sympathetic dysfunction also can happen. So it could be a damage, or see, the dysfunction is, you think one thing, you anticipate. No, but it can cause some dysfunction and present differently. So that is the reason why it is not a fixed thing as we anticipate. It can have multiple presentations. That is why we see one patient with one problem may come with multiple types of pain. As we go through, we will see them in detail. Okay, so so far, any doubt anybody wants to ask? Or am I too fast or okay?
Please respond.
Okay, very good. Thank you. So the main thing is so far, like, what is it? And what is that we need to understand? That is the important thing. This neuroplasticity is something which we need to understand. See, many systems of our body have all these additional capacities. So that is why the presentations are different. Okay, next slide, please. Next, we will go on to the types of pain. I've just got a case history here. You will have this case in mind, and we will go through, and at the end of it, we'll come back to this case again. 38-year-old male diagnosed with CA oral cavity. He is the breadwinner who is married with 2 children, 9 and 2 years old. Wife is a housewife, and at present, he's unable to go to work as he's having treatment, and he's also very fatigued, both due to the disease and the treatment. And some issues what he's having and which is bothering him too much is because he was the breadwinner, no income for living for the family, and his children's school fees. At least one child who is already in school, how am I going to pay? So these are his concerns. Okay, so this, you all have this case history in the back of your mind. We'll go through with the rest and then come back to this, because always as medical professionals, no, if you have something what you will be seeing day to day and discuss any topic, you will never forget. Okay, next slide, please. So we saw what is neuroplasticity. Next we come to, because I was telling we need to know the difference between nociception and pain. So what is it? So coming to nociception. What is nociception? That whole pathway that we saw refers to the detection of the stimuli by the nociceptors. That's why I said there can be different. Nociceptors can be peripheral, stretch receptor, pain, pressure, various type of receptors it could be based on the site. As I said, it could be skin, it could be joint, it could be organs. So various places, various receptors are there. So site where it is causing the pain, there it is detected. And what happens? Followed by transduction and transmission. That is what the whole nervous pathway does. From the periphery to the brain and then back. Okay, so mainly from the periphery to the brain. That process is called as nociception. Okay, next slide. So this is something we need to know about nociception. So once you understand that, and I've already told about pain, that pain is not a simple conduction alone. It has other abilities also that it can modify. So the brain element all comes into play in the modification process. And I will just give some more insight onto this before we go ahead to the next one. What happens is, I was telling the modification. What are the various modifications that can happen? One was collateral, as I said. So there, instead of having one fixed pathway, you can have additional. But if it was just a sensory stimulus, instead of the sensory stimulus alone, you could have add-on sympathetic symptoms also. That is one. Next, something called as ectopic. See, you would all be familiar with ectopic in the cardiovascular system. What is ectopic?
Outside means outside from the natural state.
Exactly. Very good. Well done. So what? So there is a fixed area out of that area. That is ectopic. You have a normal. For example, in the cardiovascular system, you have SA node, AV node, Purkinje, and it goes to the. But instead of following this pathway, somewhere else one trigger comes. Exactly, same thing you keep in mind. In the nervous system also, ectopic firing. You have, for example, stimulus is some injury happens in the arm. It is a sensory injury. But as I said, sympathetic or nearby new neurons, ectopic firing, new neuronal sprouting, they say. So these type of things can happen. So a new origin site can develop, or new neuronal sprouts can happen. Up regulation or down regulation, they say. That means increased. One symptom can be exaggerated or decreased. So, and some genetic changes can happen. So these all are the modifications. And about the chemical mediators, which I was telling, that is called, when you take your textbooks and read, it may have something called as inflammatory soup. That means what? It all the prostaglandins, bradykinin, all those chemical mediators, they can be in some quantity, or the quantity can be increased. So the inflammatory soup or the chemical mediator release can be increased, double, triple, like that. So these are the various mechanisms which can happen. So these are some of the mechanisms which happen in the periphery. Similarly, some mechanisms can happen in the central nervous system also. All what I said in the periphery are called as peripheral sensitization. So peripherally, so many changes can happen and make the pain more, or from one nature to multiple natured pain. Similarly, something can happen in the central nervous system. What can happen is, couple of things can happen. The threshold, or normally for some amount of stimulus only pain can happen, whereas that threshold can be lowered. For low intensity itself, the dorsal horn can respond as severe pain. So threshold variation. Next is called as something called as amplification. What is amplification? Anyone can answer. What does the English word amplification mean? Amplify.
Increasing.
इंक्रीज होना
Increasing. Very good. Now, what was the second? Increasing, I heard. The second one I didn't hear. Go ahead.
मैम सेम ही बोला था इंक्रीजिंग
Yes, exactly. Yeah, बहुत अच्छा है. That is basically, that's what. It is made louder. So from low to high. Okay. So that is exactly, that is what happens. So the central nervous system, what it does is it amplifies. So makes low pain to high pain. It has that ability or capacity. So again, that can be short-lived or long-lasting. When you read about this, these are two terms you will see. You will see as wind-up phenomenon, central sensitization. Second one, wind-up is short-time effect. Central sensitization is the same amplification, but lasting very, very long. So these are the various, I said the central nervous system modifies. So how does it modify? These are the various ways it will modify. Okay, so is that clear to everyone? And then we'll go on to the next thing what we have got, the different types of things. If anyone has any doubt, please ask.
Yes, ma'am.
Yes. Okay, then. Very good. Okay, next coming to the types of pain. No, the previous, yes, that slide. Thank you, sir. So as we saw, appendicitis or any surgery, pain in those situations is acute pain. Okay. If the same pain lasts for long duration, for weeks and months, then it is called as chronic pain. And the common examples are what are mentioned there. When there is pain in diabetes mellitus, arthritis, tumor growth, this is a common thing. And in that, you can, these are all very common. All what I mentioned here, do they have pain for short time, or how long do they have pain? In, for example, in diabetes and arthritis.
Chronic pain, ma'am.
Long time.
For long lifetime also they can have. Okay, so that is why. So when it is more than 6 to 12 weeks, that is roughly 2 to 3 months. If it is more than 2 to 3 months, it becomes chronic pain. Then comes somatic pain. As I said, in the joints, some pain in the joints and deep tissues, that is called as somatic pain. Next one is visceral pain, like organs. You may have pain generating from the organs. That commonly is in the gastrointestinal tract, and those type of pain are called as visceral pain. Next slide, please. This slide again is quite important because the previous slide, most of the things you would have been already aware of. Whereas in this slide, you've got some of them which are new. Okay? New in the sense you need to know these. As I said, when you will be seeing more patients, these are some of the symptoms which could be there, which should not be missed. Okay? In that, first element is neuropathic pain. What is neuropathic pain? Neuropathic pain is that which is caused by damage to nerves, resulting in increased firing. All explanation that I gave so far, how a pain could be made intense or complex, that is neuropathic pain. So basically, it is caused by either actual damage or potential damage, and the mechanism is not a simple direct one. It is due to the neuroplasticity. So in neuropathic pain, you can have a big list of pain all under neuropathic pain. I will give you some examples because you might have seen those patients, and now hearing this, you'll putting 2 and 2 together. We say, when you hear this, what you have already known will make more sense. For example, people who have radiotherapy, chemotherapy, or even any type of long drawn diseases, those type of patients can have some element of neuropathic pain. Patients undergoing chemotherapy and radiotherapy is very common. You might think where from, because their pain will be modifying and changing. That is because of the large amount of, because neuropathic pain again cause could be due to ischemia, nerve damage. So multiple factors can cause neuropathic pain. So for example, in chemo and radiotherapy, when it is extensively used, there can be some amount of ischemia and there can be some amount of nerve damage when radiotherapy is given and all. Okay. So now when you know, that is why we say, if you know what happens, then you will understand why the pain, why they are presenting in pain. Okay. So neuropathic pain is a big element, and multiple causes and reasons can cause neuropathic pain. Similarly, diabetes can also cause neuropathic pain. Alcohol, excessive alcohol, that can also cause neuropathic pain. So multiple neuropathies, polyneuropathy, all that can have neuropathic pain element in it. Okay. And next thing is allodynia. Pain resulting from a harmless stimulus. Normally, something should not cause pain. Just good example for that is, does touch cause pain normally for us?
No, ma'am.
Very good. So normally,
No, ma'am.
normally touch doesn't cause pain. But you may be seeing, or you might have seen also patients telling, I have pain when my own clothes touch my, like for example, if someone has knee pain, they may say their own sari or dhoti, when it touches their knee, it causes pain. So that is allodynia. That is again one type of neuropathic pain. So you will see. So a harmless stimulus, it ends up causing pain. That is allodynia. Especially, it is a very good example of neuropathic pain. And many of the chronic pain patients do complain of this. Next is something like allodynia, small stimulus causing large pain. For example, small pinprick is giving pain like cut by a knife. So that is hyperalgesia. Hyper means exaggerated or increased. So exaggerated response to a normal stimulus. So these two, allodynia and hyperalgesia, are some of the types of representation or presentation of neuropathic pain. And last one mentioned here is referred pain. Pain felt in an area other than the site of origin. Can anyone give me examples for this?
Renal stone, ma'am.
Okay.
Sciatica.
Yes.
Myocardial infarction.
Very good. Well done, team. One more thing, what I generally say, because nowadays many or most procedures are done under laparoscopy. After you finish, when someone has had the laparoscopic procedure and they go home, what is the advice that you give? Where they can have pain. So all what you're telling is fine. Phrenic pain, where will they feel the pain? They would have had abdominal surgery, but where will they have the pain? Where they can anticipate to have the pain, and what would you advise them? Shoulder, correct, very good.
Shoulder.
So these are things. See, the surgery was in the abdomen, very good. Yes, Dr. Preeti. So the surgery was in the abdomen, but they're going to, we tell them, you may have pain in your shoulder because the air under the diaphragm irritates the phrenic nerve and causes the pain in the shoulder. Well done. So that is all what you've said. All examples what you all mentioned are good examples of referred pain. Myocardial infarction, they can have pain in the arm, they can have pain in the chin, all submental areas. All those are very good examples, which all of you are. Sciatica, all these are pain, exactly what is mentioned here. Pain felt in an area other than the site of origin. Very good. Next slide, please. So these are the various types of pain we have seen. Next, okay, I know all about it. How am I going to see, and why do we need to assess? If I know that's enough, is that what we need? Or can someone give me some salient points? Why do I have to know to assess my pain?
Ma'am, severity of the disease को पता लगने के लिए.
Very good. Disease कैसा है, कितना बड़ा है? Okay. Next one.
To assess intensity of the pain.
Okay.
To assess the site of pain.
That's all. To find out
To make the
where
choice
what
of drug.
To make choice of
To make the
drug,
choice of drug.
Okay, very good. Then
To assess site of the pain.
that's all. All site name, that all we will see. No, why do we need
Further management of the.
And then next thing is that you need to have a baseline.
Classification of pain.
And
for diagnosis and prognosis.
Yes, diagnosis, prognosis,
and
management.
prognosis.
And next is also management. You know how it is. You want to do something, and important thing to keep in mind is you have to always reassess. Okay, because this assessment and reassessment is very, very important. First, you have a baseline. As I said, main thing, if you putting all your voices together, first Why do we assess? To know how the pain is, to get a baseline, to have management, to know the type of pain. Because knowing the type of pain, you can give the correct treatment. Okay. So all these elements are there. And on top of that, there are some more information also, like you do all these collection of data for research purposes also. Okay. For research and also to assess your own quality of care. So this is how I did. Have I done the right job? Have I benefited? Have I given benefit to my patient? Or is that not so? So you can also get additional information from having a proper assessment. And finally, important thing is assessment is important because you start some treatment. You keep on assessing. Only then you will know whether your treatment is beneficial or not. So assessment is very, very important. Next slide, please. You all mentioned various components. So this is a descriptive way. As you said, we need to know the site of pain, extent of pain, duration of pain, radiation of pain, and then what, like the next two, aggravating and relieving factors. What makes the pain worse? What makes it better? Okay, that is important because all these are going to give you clues to clinch the diagnosis. Not only diagnosis, okay? We saw so much about it. If you find out all these things properly, you can see where from, what type of pain, what is causing it. All what we saw, the pathophysiology, everything will be, we can derive at everything, knowing all these factors. Then last one is very, very important. We saw pain is a sensory and emotional element. So what impact is it causing on daily activities? Are they able to do everything what they need to do? Or are they able to sleep well? And has it changed somebody's personality? This is very, very important. I'll give you some simple clues which you will be seeing when you will be seeing patients. Okay, someone may come and say, for example, someone was a very quiet person. He was someone who was very calm and quiet. Okay. Suddenly the family or the close relatives or the patient themselves may say, I find a big deal of difference in me. I used to be able to tolerate things and do everything very well, but now I get angry for anything and everything. So they can say something like that. Or someone who was very happy doing things, having very good social activities and things, they may turn to something, oh, he doesn't even speak now. He is totally quiet. Even if I ask 10 questions, only one answer comes. So that is the impact of change on personality a pain can cause. Okay, so these are important factors. And another thing to be kept in mind here is pain and mood have a strong wrong link. Okay, I'll repeat. Pain and mood have a strong wrong link. For example, someone is in very low mood, their pain will be very, very high. In contrast, if someone is in very high mood, the pain will be low too. For that, normally I give a simple example. Okay, someone is having headache. They have headache, but they've got already planned to attend a party. Okay, then the same person's headache will be different. Next way to see is same person has headache, but no party, nothing, is going to be by himself, he or she. That 2-3 hours of having the headache, no one with them, how they will go about with it will have totally, these two examples what I'm giving are like two ends of the spectrum. So this is what you have to remember. If you have these two in mind and you imagine how it will be. All this 40 minutes, what I've said, personal experience, life experience, everything what I said will fall in these two. So the same pain is there, but see the situation and other things. Think about yourself. If you were having headache and you have a very best, your classmates or some meeting you're having, you're going to dance and have fun. Will you stop doing everything just because of the headache? Or
No.
in contrast, you're going to be by yourself and you don't have anything happening like that. So impact on daily activities and personality is very important. And this we need to understand to grasp the whole pathophysiology. And then this you have to keep in mind when you're seeing patients also. And there is nowadays very strong evidence to all what I'm telling with brain MRI studies they've found. They see the blood flow of someone. As I said, no, if they do fMRI, they're called. If for someone who is in pain and in a party and in pain and by themselves. So they have shown lot of blood flow variations, chemical mediator variations and things like that. So these are all, there are strong scientific connections to all these. Okay, next slide, please. So what we have seen so far is normally assessed in this way. So all what we saw only come into, this is a normal mnemonic which is used to assess pain, called as the PQRST. In that, if you see, what provokes the pain, see what you saw, what makes the pain worse or what aggravates it. What is the quality of pain? You saw no pricking pain, stabbing pain. So that is the Q component of it. Does the pain radiate from one place to the other? Okay. And next, everyone, all of you said, what is the severity of the pain? Mild, moderate, severe. What is the timing of the, like how long is the pain? Those element of it, of the nature of the pain. Okay. So this is one of the common assessment method used, called as PQRST. So the previous slide and this one have the same element, but this is one of the common modes used, or the mnemonic, for you to remember and assess pain. Next slide, please. So for assessment, there are very many tools and scales and everything present. Okay. I will give you some information. The best thing what we generally say is, you have to make something which will work for your patient. Okay. Because some demographic area, you may have all educated patients. In another area, you may have all patients. You may have a big cohort of patients, but they may not be educated. So that should not stop you. So you should know what all is available, but you make something which will work for you in your area. Okay. So I'm going to give you a list of stuff, what is all available. Do pick from this what works for your area. For acute pain and for chronic pain, we have separate tools available. For acute pain, you have something called as the numerical rating scale, visual analog rating scale. We'll see in the next slide what they are. And dynamic means when sometimes patients may say, I have pain only on movement. When I'm not moving, I don't have any pain at all. So to assess the pain in movement, that is dynamic. And as I said, baseline pain assessment. All these you need to know. To where do they start and where do they progress? And then regarding chronic pain, when the pain becomes chronic, as we saw, it has many other components also, other diseases also we have to assess. And when we go on to chronic pain, also multiple factors, sleep, mood, depression, there are so many components, nearly like 30, 40 elements are mentioned in these chronic pain assessment tools. And neuropathic pain means we saw allodynia, hyperalgia, all those also, all what you have seen, no, regarding chronic pain, they all have to be assessed. Then distress, there is something called as a distress thermometer. So like that, there are n number of things available, but you follow something which will work for your area and your clinical setup. Okay, next slide. So these are the next 2-3 slides will give you all what was mentioned in the previous slide in pictures. So the top one, what you see is the number. Okay, you can ask patients if 0 is no pain, 10 is maximum pain, tell what your pain. Some may say, some may not. Okay, no problem. If they say verbally mild, moderate, severe, that is what is correspondingly mentioned in this. Okay, so if 0 is no pain, worst pain is what? So all these, no, you follow something which will be comfortable for you to convey to the patient and the patient to respond. So that is what this is. That is what is given. Numerical rating scale. Everything in this picture is self-explanatory. Next slide. Same, like pictures, faces. These are the Von Becker's faces, it said. So this is another way of mentioning. Next slide. This is called as a body chart. This is something very simple and anyone, educated, not educated, anyone can follow. And this is something used widely. And you can use multiple colors to indicate different types of pain. Or another way is the same chart, you can use it for reassessment also. First time you use one color, and then the next time the patient says, for example, first time the area of pain was wide, for example, 4-inch diameter. Next time they come, they say, yes, the pain is there, but it is less now. So you can mark with a different color in the same chart. So like that, no, these are, you make it convenient for you, tailor make it, we say, so that it can be used conveniently to your need. So like that, one chart, see, you've got the body represented in front, back, because if you give this to a patient and ask them to mark, they will comfortably do it. Okay, so either they do it, or if they don't know, you can ask them and fill. So there are so many ways of doing it. Next slide. So again, for chronic pain, you have these various questionnaires, and quality of life assessment also is one of the things added on to that. And then in this note, you can go on and on. For dementia, there is an additional scale assessment and how. And then for children, there is a separate scale. And then, if, as I said, no, any chronic problems, diabetes, arthritis, all that, there are umpteen types of scales. And neuropathic pain, you have to also ask allodynia, then any sensory symptom, heat. Some may complain of, I feel something hot in my leg, I feel something cold. So sympathetic components can also be represented. Next slide. Cancer pain. Okay. Last but not the least, this is also equally important. WHO has done a lot of work on picking up, treating, and doing as much as possible for cancer pain. So in 1986 itself, one guidelines was released, but still they feel globally cancer pain is not yet managed to the extent what we would want to. And why they feel now like assessment and availability of drugs may be there, but the drug reaching the exact person. For example, even in India, if you take main big cities may have, do all rural areas have the analgesics which a cancer patient will need? So that is where we are lacking, and that is where we are all heading to work to achieve that, so that we take this pain relief to where it is needed. So we have all got a task ahead in front of us to achieve that. So that is our aim and goal, to take this pain relief option available to the nook and corner of India. Okay, next slide. And for that, you have something called as an Edmonton symptom assessment tool. Or what this does is, the same what we have said, but in cancer pain, if you see, the whole thing is listed here. The top one and the last one, pain and shortness of breath, they say it forms nearly 60 to 80% of the symptom. Okay, that is something which is important to be dealt with. And all that in between. See, normally cancer patients, they are very weak and frail. They have loss of weight, loss of appetite, very common. And they have nausea and vomiting also, either due to the cancer per se or chemotherapy, radiotherapy, when they're on all that. So all that. And then because of all this, their activity is reduced. Their well-being is not okay. So that leads on to depression. So all these mentioned between pain and shortness of breath are all interrelated. So you need to assess all these also to get to the management properly. Okay. And then this, this is from the MD Anderson pain inventory, it is called. And as I mentioned before, there are separate additional tools also if someone has dementia and things which have to be kept in mind. Okay, next slide. So now we come, if you remember the case that I had mentioned, we'll go back to that case and have that in mind. I'll repeat all. We'll just see that and go back to the last slide again. Okay, this 38-year-old CA. He's a breadwinner. He has 2 children. Wife doesn't go to work. And he himself can't go to work. So the problem that he's having in mind. Now come back to the last slide. Thank you very much. Next one. Okay. So with that case in mind, what all these are this is called as total pain based on Cicely Saunders, who is the founder of whole palliative care for the whole world. Okay. So if you have this in mind and have the case, what I mentioned, does that patient have physical pain? Yes. Like the 4th or 5th element in that was, he's fatigued and tired and he's having so many pain and the disease per se is going through the treatment also. So he has physical pain, the physical pain component he has, okay, due to treatment. Fortunately, this patient doesn't have comorbidities, but he has physical pain, adverse effects of treatment, all that is there. Then you have psychosocial. Yes, he has fear of suffering, depression. Yes, how is he going to manage? All that anxiety is there in him. And all this anxiety can lead to anger also. Okay. And then comes the social element of it. Worried about future of family. How will he pay fees? All that was there. Financial concerns. Loss of job. Loss of role in and social status. Of the 5 elements mentioned in social pain, he has 4 at least. And then last but not the least, spiritual pain, hopelessness, fear, loss of faith, anger at whatever he can have. Why me? Why should I suffer? Okay. So this is what is mentioned as total pain. And this is what, from the beginning, if you connect, how we started off with the definition. And now all of you yourself have seen with that case that how it plays out, covering all the components of various types or various aspects of the total pain. So that is why we have to treat his physical, psychological, social, and spiritual pain too. And down the line, you will have few sessions on all of these management options through your course. Okay, next slide. Thank you very much for patient listening. And we can, all of you can ask questions, or we can go, you can come out of the presentation and we can have a discussion. Or
Thank you, ma'am, for the wonderful presentation. Anybody have any doubts?
Thank you, ma'am. Today's session was so interesting and full of knowledge.
Okay.
Are we having case presentation, Shiva?
No, ma'am, no.
Okay, okay. I just wanted to.
Okay. If they have doubt, we can clarify it.
Yeah, yes. No, the main thing is that, so any like have you all understood the concept that it's a complex pathophysiology? That is something to be understood properly. If anyone wants any clarification, I can take through. And the case and the total pain, that is another important thing, because connect those two. That is why I brought up that case, and so that all of you are going to be seeing the same. Okay. So when you see the patients, you look at all these components. That is why we say something as it's a multi-system involvement. So when there is some problem which is multi-system, what management we need? We need a multimodal management. So you have to cover everything. If you cover just the physical element alone, may not be enough. So that is something to be kept always in the back of your mind. So whenever you see patients anymore. So if you start having this concept, so you have to understand, you have to have the knowledge. That's why in the beginning I said, if you understand the concept well, you will definitely treat well. No doubt in it at all.
One question.
Excuse me, ma'am. Hello.
Yes.
Pain. One concept is of pain, and what about the tenderness? Is it the same thing?
Ma'am, you are muted, ma'am.
Radha ma'am, you are muted.
Hello.
Sorry. See, you have something called as a sign, symptom and sign, no? So symptom is tenderness is the sign that you pick up. Patient says, I'm in pain. And then when you see, and then there is tenderness, that is the sign. You're all aware of symptom and sign, no? That is what it is.
Okay. Thank you, ma'am.
See, always I say, better to have queries, okay? Don't think, see, this is a platform, we are all doctors have come here to learn, okay? If you are hesitant to ask queries and have a doubt within you, that may not be good for you. So don't have any hesitation. Better to clarify things in such platforms.
Ma'am, one question. Can elaborate allodynia, please, with some kind of example?
Okay. Always this allodynia, no, is something, because any of you are either pain practicing doctors or at least palliative care practitioners. Is anyone like that is there in this group? If so, please tell me. I will explain, but just I wanted to get some input.
Ma'am, so this group is community health officers. They are doctors, but they are especially doing the leadership role in the community. So that's what I understand from this group.
So no one is already practicing. Is that correct?
Yes.
Yes, madam.
Yes, ma'am.
Yes.
Can one of you speak and say, like, You're all community health worker, community health doctors.
Yes.
Yes, ma'am.
Okay. So no one in palliative care.
No, ma'am. So they are doctors, but they will learn if they want to implement palliative care in their community. So these are the person to learn first, and they will be implementing to the community people. That like yeah. So in
Okay. So okay. In that case, no, this allodynia is a symptom which is unique to neuropathic pain. So that is why you might not have seen. I will give you examples. Normally, when you see either a chronic pain patient, any patient who has pain for long duration can have allodynia. Like common examples that we give is like it's someone who has long drawn pain, or even this cancer pain. These type of patients, for example, they have pain in the knees. So what they will come and tell you is their own clothes. Like for example, someone is wearing sari. So they say that normally touch of sari or touch of a dhoti does not cause pain. Whereas these patients will come and tell you that, or their own hand touching the knee by chance. Sometimes still I'll tell you, flow of air can cause pain. So they will come with these symptoms and telling, if someone touches my hand, or my hand by chance touches my knee, or the clothes touching. See, normally these don't cause pain. So when these symptoms are causing pain, and then the cause is the all the pathophysiology what we saw, it is modification and dysfunction is what is the cause for it. And normally any chronic neuropathic pain patient can complain of this. Have I clarified? Because these one you have to see patients to believe. And for example, like in our ward, we had a chronic pain patient who was complaining of this. And even cancer patients can complain. Cancer pain, they can have this symptom.
So because especially diabetes also, diabetic neuropathy. And then cancer, if the tumor is compressing to the nerves, no, so that time the patient experienced neuropathic pain. So and another thing is the chicken pox, no, the
shingles. And what Shiba is trying to say
And
is,
in herpes zoster,
exact.
herpes also.
Correct. That is what Shiba was trying to say. See, the herpes zoster happens how? They would have had shingles many, many years ago. And then the virus stays in the posterior horn. And then after many, many years, it comes up as another viral infection as shingles. And when shingles comes and goes, shingles will come and go, okay? But the pain persists for even 2 years. That is what is called as post-herpetic neuralgia.
Ma'am, in herpes, there are also black spots and pain persists after so many days.
Exactly. That's what I'm trying to explain. So normally for that herpes, it will be only in one neural dermatome. For example, if it is on right side, it won't be on the left side. So it will be on one nerve distribution, and initially it may come as small dots or something like that, skin eruption. It may come, and that is what you're telling, it may leave marks. Okay. But nowadays, again, you having started this topic, how can you overcome? There are methodical things. First, you have to treat that herpes with antiviral straight away. Okay, 5 days antiviral, 5 days or 10 days antiviral, and give them some cooling, this calamine lotion type of thing. If you manage the herpes very well and give good medications for pain relief and things that time, they may avoid, or to a very great extent, having long-term pain. If you don't manage that initial event properly, they may end up having pain for 2 years also. Those type of patients will need
antiviral only
antiviral.
work within 72 hours only. After that, we can't manage with the only antiviral drugs.
Correct. Exactly. That's why I said immediate.
On the 1st of January, I have seen that case, herpes on the forehead. The patient have black spots and complaining for the pain. So I have go for the teleconsultation, and the dermatologist asked me the same thing, and she explained me this pain can persist for so many years or so for so many.
And for them, you will all study in your dues in the sessions below. The anti-neuropathic medications are the gold standard help for them. And they, like, if you start your antiviral and treatment early,
pregabalin may be a choice for that.
Gabapentin, pregabalin is the medicine for it. So that's all. So like that, no, dealing with these things. So if you don't know all this, will you be able to treat? So that's all. See, as physicians, no, we need to have all-round knowledge. First, we need to have the knowledge, then also know where and how to do, and then practice, get the benefit finally. So everything together is important. So see, for example, this herpes came and go. Why should they have pain for 6 months, 2 years and all? Why? You all know the answer from session today. All this complex neural response, they have the ability, the neuroplasticity, they change and modify and present in different ways, causing pain for longer duration. And then next, we know how to manage them also. So it's not impossible or to deal. It can be managed appropriately. So coming to allodynia, did that whoever had asked, has my explanation satisfied your query?
Yes, madam.
Thank you. Once you start seeing patients, you yourself see, if you know this, when someone comes to you with that, you will say, oh, this is what it is. That's all. So neuropathic pain is something, it can present in so many ways. As I told you, sometimes different shearing injury, it could be not a direct like fracture or something, need not be there. Ligamental tear, so many type of things are there, no? Those can lead on to chronic pain. And you have all these in mind, which will be helpful. See, so much of information and things have come in the last 20 years or so. So that is how that has widened our knowledge in pain. And as a result of it, better management for patients. End of it, as I always say, for all of us, we all work towards patients' best interest. What can I do so that my patient is better off in all ways? Okay. So with that in mind is what will be that is our aim and goal. Good. Anything else in the chat box or anything like that which needs clarification?
No, ma'am. No.
Good.
Okay. We have 10 minutes more. If anyone wants to share.
If anybody wants to ask anything, please go ahead.
Or you can share your experience also, as Dr. Virendra said.
Yes.
If you want to
very
share,
good.
Your experience so that others can get benefit, no? So if you want, you can share.
Main thing with the assessment part of it, no? each one of you may be following something. Okay. You have to take something from the session and see if you can modify or do something to get maximum information from the patient to help in your management. So that is what you have to follow. So everyone will be following various ways and means of doing it, and you have to do it which will be beneficial for your area. So have all these in mind and then see what will help for you. So that is what we generally say. So you pick it up and use it to your demand.
Ma'am, some patient says when they are combing, they feel like pain. So it can also be
Yes,
allodynia.
exactly. See, that's common. Please, even I'll give another example. No, like when that's all. It is all the nerve in that region. That is why, as I said, no, these are some examples. Normally, which should not cause pain, the same thing causes pain is allergy. That is what. So normally that's why I say general touch doesn't cause pain. No, otherwise we won't do handshake. Will we do? So something which should not cause pain, when that causes pain, it is not normal. It is abnormal. See, trigeminal neuralgia, what he's telling, that patient, I don't know, but I'm telling someone who has trigeminal neuralgia can have that symptom. So these are all various things. As all of you start seeing patients, something related to that will make more sense.
Ma'am, in ophthalmic migraine, they can be.
Yes, headache for that matter, no? Headache is a big entity by itself, okay? You have tension headache, migraine. Headache itself is one big topic because just some abnormality, refractive problems, they can have, like chronic refractive problems which are not corrected, can have headache. And then they can have some other issues, sinusitis, any neurological things. So tension headache, migraine, all these are there. So various types are there and to be kept in mind. Anything else you wanted specific with headache or what was your query? Dr. Virender? Was it Dr. Virender who asked?
Yes, ma'am.
Yes, ma'am. Thank you, ma'am.
That's all. So because again, no, for that also, if you know, you have to have all these in mind and exclude one by one, and then come to a diagnosis, probable diagnosis, and then go for management. Again, there also for headache, we generally say you have very many modes: medical, non-medical, pharmacological, non-pharmacological, all works. Okay, so you have to have all that in mind. You will have at least 2 sessions on pain, isn't it, Shiva? 2 or 3 sessions on pain.
Yes, ma'am.
So you will have a lot. So in detail will be covered. So no worries.
So today, thank you, ma'am. We have learned many things. So I would like to highlight few things, especially pain is one of the most important symptom in palliative care. We need to do the proper assessment. Madam was saying like how to assess pain and all. So pain is a subjective experience. So we need to believe the patient words. That is the important thing. We should keep it in mind all the time. So you have to convey your this knowledge to your staff, because especially MBWs will be going and seeing the patient in the community. No, you have to share your knowledge with them so that they will get a good idea about pain. And the second thing is you have to you have learned many type of pain, especially neuropathic pain and nociceptive pain. You have to understand that. So what are the features of the different types of pain, nociceptive pain and neuropathic pain? We have learned, discussed many things today. And the next thing, so you have to do the proper assessment. So that you can use STPQRST. So if you do it like that, you don't miss anything. So what is yes? Site. The next, the thing is D. D is duration. How long the pain is there. And then P. P is provocating factor and palliative factors. Is there anything will cause pain, increasing pain? Is there anything decreasing pain? That provocating factor or palliative factor? And then quality of pain. What are the types, what kind of pain? Just aching, pricking, shooting, that kind of things you have to assess in Q. And then severity. Severity, then you can use the numerical rating scale or the phases scale, Wong-Baker phases scale. So 0 to 10 scale you can use. So this is the subject to explain. The patients can only to explain their the severity of pain. You can use the 0 to 10 scale. Then T is the temporal factors. So whether they are able to sleep, they can able to eat, that all. So if that pain is affected their activities of daily living, these all comes under temporal factors. You have to use these things, ST, PQ, RST, you won't miss anything. If you do it properly, definitely you can make a good treatment plan, and then the patients will get benefit. So our aim is to relieve the pain. And another thing is total pain concept. Madam has already discussed. So that is also very, very important, because if the patient is having psychosocial issues, their physical distress will increase. Okay, the intensity of the pain will increase. So you have to give a proper attention to that area, other area also, because if they have a psychosocial issues or a spiritual issues or a other social problem there, definitely the physical problem will increase, and your medications will not help fully. So if there is a psychosocial issues there, you have to include a social officers or a MPWs. You have to tell them to listen their problems, and so that we can able to elicit their problems. And if possible, you can do something for that part also. Otherwise, at least you have to listen their that other psychosocial issues and explore their problems. So we need a teamwork. Okay, ma'am, anything you have to add?
Yes, Shiva, like all what you've added, I think it was quite interactive also. No, they have been interacting from the beginning, and overall main concept has to be understood, and then the other sessions will add on. So if you have this concept, now every session on top of it, you add on, your doubts and queries will be clarified, and then you map or match, and then everything is clear. Yes, Shiba, I think we have covered everything.
Yes, ma'am. Thank you.
Thank you, Radha ma'am, for the wonderful and
there's a query on asking for some attendance query, Shiba.
Yeah, that Sangeet will.
We will take care out of the group, ma'am. Thank you.
Okay, thank you all.
Good luck to all. Good luck to all. And
thank you, ma'am.
Thank you all for participating. Thank you, Shiva ma'am, for facilitating. Thank you all. Let's see in the next session.
Thank you, ma'am.
Thank you very much. Good luck to all.